Hello and welcome to the Wiley podcast series Knowledge to Impact, where medical education meets real-world change. This series aims to deliver latest content updates from our Knowledge Hub program. This is our fourth episode on cancer cachexia, a progressive muscle-wasting syndrome that significantly diminishes the quality of life for many patients with cancer. The Cancer Cachexia Knowledge Hub was developed in partnership with the American Cancer Society and has been supported by an educational grant from Pfizer. In this episode, we are joined by Associate Professor Richard Dunne, who shares key highlights on cancer cachexia from the 2025 ASCO annual meeting. In this part one of ASCO Highlights episode, Dr. Dunne explores the research revolving around cancer cachexia, its progression, methods for clinically scoring and staging the condition, including novel approaches, and factors associated with its incidence. This discussion was originally broadcast as a webinar. A link to the original accredited activity, including information on how to claim credit, faculty disclosures, and the slide presentation, can be found in the show notes. We're glad to have you with us, and we hope you enjoy this episode.
Hello, my name is Richard Dunne. I'm a medical oncologist at the University of Rochester in Rochester, New York. I recently returned from the ASCO annual meeting in Chicago, and I'd love to share highlights from the conference and research revolving cancer cachexia. Just a brief introduction. Cancer cachexia is a progressive syndrome characterized by a loss of muscle mass with or without the loss of fat mass that cannot be fully reversed by nutritional support. And cachexia leads to poor patient function, poor quality of life, and decreased survival. The pathophysiology of cancer cachexia is characterized by a hypercatabolic state that is driven by tumor-derived factors as well as a pro-inflammatory state. Males and females, as well as those from different age groups, diverse races and ethnic backgrounds, may experience cachexia differently. So a classification system of cachexia was proposed well over a decade ago by an international consensus that also developed the most commonly cited diagnostic criteria for cancer cachexia. This commonly cited criteria is for patients that have at least 5% weight loss or greater than 2% weight loss and a loss of skeletal muscle mass or low BMI as being diagnosed by the cancer cachexia. And this group proposed this staging system that broke up cachexia into several stages. A pre-cachectic state that is characterized by minor weight loss, cachexia, which fits the definition I alluded to and is listed here on the slide, and refractory cachexia. Refractory cachexia is thought to be cancer at end stage that is irreversible and is associated with a very poor prognosis. One of the criticisms of this staging system is that there are not real strict guidelines and criteria to fit patients in each stage and gives more general guidance. So in the clinic, trying to fit patients into one of these stages of cachexia can sometimes be difficult and also somewhat subjective. So I'd like to review the first study of the presentation, which is titled A Novel Staging System for Cancer Cachexia. This was presented as a poster at the ASCO annual meeting and was led by Saeed Jaffrey from the University of Texas. And so this was a prospective case control study utilizing patient data from the University of Texas Health System. In this case control study, cases were defined as cancer at advanced stages, stages 3 and 4, of those that had greater than 5% weight loss, and those that had a serum albumin of less than 3.5 grams per deciliter. The controls in this study were those with earlier stage cancer, stage 1 and 2, no weight loss, and those that had a normal or elevated serum albumin level. And in the cases, they developed a novel scoring and staging system for cachexia using the characteristics that are outlined below. Body mass index, which is a marker for metabolic health and incorporates weight controlled by height. Serum albumin, which is a surrogate marker for nutritional status and also possibly inflammation or acute illness. The neutrophil to lymphocyte ratio, which has been used many times in studying cachexia as a surrogate for a pro-inflammatory state, and resting heart rate, which is a measure of physical fitness and performance, but also is a measure for metabolic health. So a total of 109 patients were enrolled in this study and followed prospectively. The majority of patients had both lung and GI cancers, and they used the factors that we described on the last slide to characterize these patients into either a stage 1, meaning the earliest signs of cachexia or least severe signs of cachexia, stage 2, and stage 3 being the most severe stage of cachexia. And about 45% of patients fell in stage 1, 36% in stage 2, and 18% in stage 3. And they measured median overall survival for each of these stages. And the prognosis and survival became progressively worse among the more severe cases of cachexia. And these findings were statistically significant. Notably, those with stage 3 cachexia had a median overall survival of only 3.5 months. In terms of conclusions of this study, these findings represent a potential new way to stage the severity of cachexia, giving very specific cutoffs and markers that could be easily measured in the clinic or routine lab work, including BMI, albumin level, the neutrophil to lymphocyte ratio, which is usually found in most CBCs that we collect routinely, and a resting heart rate. But before being implemented more broadly, this does require a validation in a larger data set. The next 2 studies that we're going to review from the ASCO annual meeting look at differences across races and some other demographic factors in patients who are dealing with cachexia. So this next study is titled Race and Correlates of Cancer Cachexia in the Detroit Research on Cancer Survivors Cohort. This study was led by Jennifer Lynn Beebe-Dimmer from the Karmanos Cancer Institute in Detroit, Michigan. And so this was a secondary analysis of a cancer survivor cohort study. So a secondary analysis using the Detroit Research on Cancer Survivors Study, or the Detroit ROCKS study, nice acronym. And patients with breast, colorectal, and lung cancer participated. So in part of their evaluation in terms of weight and cachexia, height, weight, their medical history, and quality of life were collected as part of this study and used to help do this analysis. In this study, cachexia was defined as an unintentional weight loss of greater than 5%, or a BMI less than 20 with a greater than 2% weight loss. So this criteria you saw earlier in the slides has been called the Fearon criteria because it was based on the international consensus panel that I alluded to earlier that was led by Dr. Kenneth Fearon. So this is the most common cachexia definition that is cited still today in 2025. And here are the key findings of this study and the conclusions. Cachexia was more prevalent in Black patients as compared to white patients. There was a total of 899 patients that were included in this secondary analysis, 509 Black patients and 390 white patients. And cachexia was found in over 40% of Black patients and almost 29% of white patients. And this finding was statistically significant. Those with lung cancer had the highest rates of cachexia. So to remind you, this study looked at patients with breast, colorectal, and lung cancer. Cachexia is most prevalent in cancers of the lung as well as the upper GI tract, like pancreatic, gastric, and esophageal cancer, but also is very prevalent in colorectal cancer. It is less prevalent in those with breast cancer. This study also found that older adults and those with history of diabetes were most likely to have cachexia when compared to younger patients and those without diabetes. In the third study we'll be reviewing in this presentation was titled Disparities in Cachexia and Anorexia in Hospitalized Female Patients with Breast Cancer, a national population-based study. This study is led by Amra Awad from the Hennepin County Medical Center in Minneapolis, Minnesota. And so this was a study that was analyzing a large publicly available database. So this was an analysis conducted using the National Inpatient Sample Databases with data that was fairly recent from 2016 to 2021. And the goal was to identify demographic factors associated with cachexia, including race, income, type of insurance, and age in women with breast cancer who are hospitalized. And they used a multivariate linear and logistic regression to adjust for covariates, including demographics, comorbidities, tobacco use, and a history of anorexia nervosa. In terms of key findings for this study, 12% of women hospitalized in the U.S. with breast cancer during this time were documented to have anorexia, cachexia, or malnutrition. So the rates of cachexia may be lower in cancers of the breast. However, given this is such a prevalent cancer in the U.S. and throughout the world, it shows you the scope of how many lives cachexia may affect, given how common breast cancer is. And what was also found is there were higher odds of anorexia or cachexia being found in patients that were greater than 65 years of age. Also, that there were higher odds of anorexia, cachexia in African American patients, which was also seen on the last study we reviewed. And there was also significant findings in those that did not have private insurance. In this study, income was not found to be associated with higher odds of anorexia, cachexia. So in summary, trying to put all of these great presentations together, cancer cachexia is associated with decreased overall survival, and more severe cancer cachexia can be tied to some of the poorest outcomes, including the worst survival, as was seen in the novel staging system of cachexia study. Additionally, older adults with cancer are more likely to suffer from cancer cachexia compared to younger adults. Multiple factors, including normal aging-related sarcopenia and types of cancer seen in older adults, are likely responsible. And lastly, cancer cachexia is more prevalent in Black and African American patients compared to white patients. Now, the reason for this has still not yet been fully elucidated. Certain social support, environmental, or biologic mechanisms that have not been discovered may be playing a role. So this should be an area of research in cachexia going forward. Thank you.
Thank you for joining. If you enjoyed today's episode, don't forget to share it with your colleagues and subscribe to our channel. If you'd like to learn more about cancer cachexia, you can access additional educational resources, including CME credit opportunities, on the Wiley Knowledge Hub. For more medical education from Wiley, visit Wiley Focus. All links are in the show notes.